All right. She. Good afternoon, everybody. And thank you for joining us. I am going to be the presenter today. At least this time it's a scheduled presentation, not an emergency presentation, so it's great. Dr. Wendosen was asking me if this is the hospital where I work. Yes, it is. It's actually a huge complex, close to 500 beds, a teaching university hospital, about 2 hours north of Chicago. So my presentation today is on arterial diseases, and I entitled it like for practicing physicians because, in part one, because there's so much to talk about. I wanted to give a little bit more of the foundation first, because the audience, at least in Ethiopia, I'm sure is diverse. I'm sure there are people who are in surgery, there might be folks in cardiology, as well as internal medicine and whatnot. And so I wanted to kind of have this as part one and more of a baseline so that in the future we can actually ramp this up and based on requests, we can take it to a little bit more of a higher level. So please bear with me if some of this talk may seem for some of you more elementary. There is room to grow into this, but I try to keep it interesting for the majority, at least of the attendees. So we'll do that. So this is my outline. So I'm going to cover a little bit more of epidemiology so that you all understand the magnitude of the disease, how it's really actually of epidemic proportions. And then we need to talk about, the basic workup of, peripheral vascular patients, what you need to do, and then understand the indications for interventions, particularly invasive interventions, and also identify and learn which patients have a threatened limb. And we are not going to talk about acute ischemia here. We are going to be talking about chronic ischemia, which can be non-acute chronic or acute on chronic ischemia. So primarily is the chronic disease that we are going to be focusing on. Let's talk about epidemiology, and it's very clear this is actually worldwide the #1 killer, by the way. It's already taken more than infectious diseases, its fair share of death. In the US alone, from peripheral vascular disease perspective, it's expected about 8 million individuals are affected by that. Granted, the majority might be asymptomatic, and worldwide, it's expected about 200 million are affected by peripheral vascular disease. And what is really scary is since 2000 until 2010, there was an increase of about 20%. And the problem is that most of this increase worldwide was actually in developing countries. There is a lot of speculation. Maybe lifestyle has changed, diet has changed, and cigarette smoking is more. And all the bad things that we did not have in the past probably are coming to our part of the world. So this disease is going to be, there to stay, and we all have to be aware of it. Another statistic that most of you need to know is from the cardiovascular diseases perspective, most of the deaths occur because of heart attacks and strokes, up to 80%. And of this, again, 3/4 of these deaths occurs in developing countries. So in Addis and outside Addis, that's probably why you are seeing now and making diagnoses of heart attacks in some of the patients that come to your emergency departments. And when I was a physician in Ethiopia, we hardly ever saw myocardial infarction. And this is not, 50 years ago. I mean, we're talking about 25, 30 years ago. And so the epidemiology has changed. Amputations are done very often. In the US, there are about 350,000 amputees. We're not talking about all of them with major amputations. Some of them may have, toe or finger amputations, but probably about 60 to 65,000 each year of major amputations happen in the US. And of those, the overwhelming majority are related to complications of diabetes. Not only the arterial occlusive disease that comes with it, but also diabetic foot infections are a leading cause of amputations if they are not recognized in a timely manner. One of the things that has been studied in the past is also that when it comes to chronic vascular diseases, delay in diagnosis and delay in referral to physicians, be it vascular surgeons or interventional cardiologists or interventional radiologists, that delay in recognizing that the ischemia is limb-threatening accounts for almost 25% of amputations. So people may get to the physician that could take care of it late, and you cannot do anything else. Here is a list of things that you need to recognize and are very important from risk perspective. Why do people, end up with peripheral vascular disease? There are risks here. The list is long, and you don't need to write anything because we'll be sharing with you not only the slides, but I'll also send a PDF reading materials that goes along with this so that you have it for yourselves. So just don't take any notes and just listen, and maybe at the end ask the questions you may want to ask. So when you look at risk factors, there are what we call the modifiable risk factors and the non-modifiable risk factors. So the non-modifiable ones are, you can't change the gender or you can't change the age, right? But a lot of the other things that you see are modifiable. You can treat hypertension, you can treat diabetes well. And smoking is actually a huge, huge problem in developing countries and also non-developing countries. That's why even the WHO is taking actually huge stands against smoking, because it is a leading cause, a leading preventable cause for vascular disease in general. Cigarette smoking has probably about 8% of it might be tar, but about 92% of smoke has actually gaseous component that have so many free radicals that do damages to, several organs, including it has effects on platelet activity. It has effects actually on the lipid profile as well. It actually decreases the high density lipoproteins, which are usually the more protective ones. It has effects on the vascular wall itself, both a direct damage and destruction of the endothelial cells. And it has also increased damages on the cardiovascular system, such as by increasing catecholamines, it increases heart rate, it increases blood pressure, and so on and so forth. So it has a lot of inflammatory effects as well, including the increased leukocyte counts, and inflammatory markers are also increased. So smoking by far is one of the most important and critical risk factors you need to really ask every patient and encourage them to stop. So one other modifiable risk factor that you see here is hyperhomocystinemia, and that may fall under the hypercoagulable conditions in general. And it's something that can be easily treated. It's a 1 milligram of folic acid a day is going to take care of it, but you need to have the test first. And usually this is something that we suspect in the younger adults, patients usually less than 50 years of age, the classical symptoms of Leriche syndrome kind of pictures. So when those things happen in people who are young, in the 40s, 50s, think about hyperhomocystinemia, think about folic acid and vitamins in general. So I have a couple of cases here to talk to you about, so that we can make this interesting. So let me see. I am not sure if I can see if I ask you questions, if I can see your responses, but I'm going to ask you anyways. So here is, for example, a patient who comes to the clinic with 65 years old, smoker, complaints of calf cramps with ambulation. So this is pain that these individuals are having with walking. So in this part of his, complaint, of course, you come and you want to do some clinical evaluation. And if we want to focus on vascular issues, what are the kind of questions you want to ask? Let me just give you a minute maybe here and see if people have some answer. What additional information do you want me to ask to pinpoint if this is a vascular issue? Does the patient have other comorbidity? Rest pain? Okay, there is another one. History of diabetes. Tolerable distance. Any other thoughts? Cool skin. So we are getting into the physical examination. So let's go further in this, the smoking, history of smoking, and the wounds, the characteristics of the pain, risk factors and complications. I mean, these are all important points. So what is actually important is understanding the location of the discomfort. So this particular patient is saying calf. So, and this is one of the commonest area of complaint in terms of pain. What happens is, if there is a peripheral vascular disease and the demand of work basically in that muscle group increases with the patient walking, and there's more demand for oxygen, and the blood supply cannot supply the oxygen, then the discomfort is in that location, which is a calf, and it's usually crampy pain that leads to the patient stopping walking. Now, it's also important to ask the duration of the pain, because as soon as the pain hits, they stop, and in few minutes, the pain goes away and they resume walking. So this intermittent nature of the claudication itself is going to be key in your diagnosis. Location is important because sometimes it might be also the thigh, or it might be also the buttock muscles actually, depending on where the blockage is, where the occlusion is. If it is an aortic occlusion, patients probably may come with more of a hip claudication or buttock claudication. And if the pain is in the thigh, it might be more of an iliac occlusive disease. So indirectly, the location will tell you, and it's important that the symptom disappear with resting. And most of the time, this patient's symptoms actually over time will progress if they are not going to do anything about it. And it is usually very clear from their description that the pain is something that starts, some say 50 meters and starts, and by 75 meters, I have to stop. I mean, so those are really very clear symptoms that they describe. And so these are the few additional questions. And so the pain goes away, they resume walking, the pain comes back. So this is how you make the diagnosis of intermittent claudication. And of course, when you have these patients, you have to do the physical examination and everything that comes with it. And I'm not going to teach you how to do physical examination, because if there is one thing I know you guys do really well is a physical examination. But I just want to add a couple of things that are going to be very important for all the physicians when you do physical examination of vascular patient. Clearly, the auscultation part is something you do on the chest, on the abdomen. That's all what we do most of the time. But if you put your stethoscope right under the mandible, the angle of the mandible, to listen to the carotid, you can hear bruise if there is a carotid stenosis. If you can put your stethoscope around the inguinal ligament, you can hear bruise if there is an iliac stenosis. Those bruises are caused by turbulences, as you know. And the same way, when you listen to the kidneys in the back, where you can hear bruise because of renal artery stenosis, when you evaluate and assess anyone with severe hypertension. The same way the smell part is critical, because a lot of times diabetic patients that come with bad foot infection, that smells really bad. And at times, patients may not take out their shoes unless you ask them to, or we may not want to do a proper examination of the feet, but that is really a very critical part of the examination you have to do. You need to really look at the feet. You need to feel the pulses, those pulses that are palpable, both in the feet, in the arm, as well as the carotid, are critically important to palpate and document. And the visual part for vascular disease is usually the lower extremities, where if there is a peripheral arterial disease, usually you will find thickened toenails. You will find the skin is thin, shiny, with no hair. Hair loss is usually very characteristic in all these patients. And so the physical examination and documenting your physical examination is critical. Now, that said, if you don't feel any pulses, you have no way to quantify what the blood flow is like. Yes, you can say there's a capillary refill, it is a second, 2, 3, or you can say the extremity is warm, and so on and so forth. But there are easy ways actually to quantify blood flow. And one thing that we do routinely is a test called an ankle brachial index. This doesn't really require a lot of gadgets or a lot of equipment. The one thing that's really important is to have a Doppler probe, which you can see right here. This continuous waveform, the Doppler probe, is important component because that is how you really want to hear the sound, the arterial sound, the pulse. And what basically ankle brachial index means is you make a ratio of the blood pressure at the ankle to the blood pressure in the arms. So what we do is we measure blood pressure on both upper extremities, and we take the highest of the two, and then we do measure the blood pressure at the ankle and make a ratio. And this ratio should be usually about 1. So anything less than 0.9 is considered abnormal. Anything more than 1.4 is also considered abnormal. And I want to know why is it considered abnormal if it is, say, greater than 1.4? Would you guys just type in, why would I have an abnormal ABI or ankle brachial index? If it is greater than 1.4, why do I say that is not normal? Can anybody write me why? So it's not compressible, stiff arteries, sclerosis, non-compressible, calcified. Absolutely, these are absolutely the right answers. So the vessels may be calcified, and you can pump that blood pressure cuff to 250, you may still have some Doppler signals. Remember, these Doppler probes usually tell you that there is flow. They cannot tell you, the quantity of the blood flow. But, you can also even listen to venous flow for that matter, right? So if you have values that are greater than 1.4, it is hardened, calcified blood vessels, and you cannot really rely on ankle brachial index. The next, test that actually, I call this more of the glorified way of measuring ankle brachial index. What this does is it measures pressure across the entire leg at 4 different stations. You can see there is an ankle, the high thigh, the low thigh, and the calf. And then, you can have the indices or the ratios at all these different stations and can give you an information. For example, if my high thigh index is 0.7, what that means is it's really reflecting of the blood flow above where the cuff is, and therefore the iliac vessels are abnormal, and therefore I have what we call an iliac stenosis. If that is normal, however, the low cuff or the low thigh cuff is abnormal, it means my problem is between the two, which is probably the superficial femoral artery. So it really gives you some sense of identifying and localizing, but not very exact in the diagnostic ways. The other thing that this does is what we call the pulse volume recording. The pulse volume recording is nothing else but these cuffs that you see are inflated at about 60 to 65 millimeters of mercury. And then what happens is the cuff sense the blood flow that is going through that extremity. And that sensation of the cuffs inflating and deflating based on systole and diastole, or that change in volume that's happening around the thigh that the cuff is applied on, is then translated in some waveforms you can see here. So these waveforms therefore reflect this uppeak to systole with a diastole which is downwards, and you can even see the diacrotic notch. So you can really tell a lot by looking at this waveform in terms of how the blood flow is, and this is called the pulse volume recording study. It's a good test to do, particularly in those patients where the vessels are not compressible. And you can see here blood pressure signs that say greater than 254, because that's how high the pressure has been inflated, and there was still not possible to occlude the vessel. And so in those situations, you get a pulse volume recording. You can also use the Doppler wave analysis, and that comes also almost in a similar manner. And systole, diastole, and you can see not only the characteristic of the waveforms in terms of widths, how flat they are, and this down peak, which is usually the diastolic phase with a systemic resistance. All these are actually heard also with the sound of the Doppler. We can see the differences between these two, where here the waveform is more blunted, and it's what we call a monophasic, whereas here you have a triphasic waveforms, which is normal. And so there is a lot you can tell, and at the end, you can also have what we call ankle brachial index at the bottom that is going to be measured for you. Here is the 0.83 and 0.54, and there is here 0.92, and we usually take the highest of the two. So in general, when we look at ankle brachial indices, we divide this in different categories. 0.4 and above is abnormal from non-compressible. Between 0.9 and 1, it's normal. Anything below 0.9 up to 0.5 is mild to moderate arterial occlusive disease. Anything under 0.5 is considered severe, and anything under 0.3 is usually very critical. What is really interesting is that the ankle brachial indices have actually a prognostic value in terms of longevity of individuals from cardiovascular disease that is almost comparable to looking at ejection fractions. In fact, if you look at people with ankle brachial indices that is less than 0.5, if you have 100 of them, probably over 10 years, there is going to be maybe 5 to 10% of them alive. The rest are going to be dead. And so it has a very bad prognostic value having an ABI which is less than 0.5. So lab investigations, I don't want to belabor you on this. It really focuses on all those things that are around patients, vascular disease, risk factors, and so on and so forth. So the diagnosis for this patient, therefore, if this patient has that pain that he described, say the ABI is 0.75, you don't have a palpable pulse in the foot, but it's warm, there's a predictable walking distance, and which is relieved by rest. That clinical scenario is what you have, then the diagnosis is very straightforward. It's an intermittent claudication. So now, what do you want to do? So the question now is going to be, with the ABI or with a pulse volume recording study, usually we cannot be 100% sure where the blockage is. We know there is a blockage. We know there is a mild or moderate or severe disease, but we don't know exactly where the problem is. So would anybody at this point for this person say that he has 0.75 ABI and has, claudication that is severe at 100 meters? Would anybody do some imaging study, be it a CT scan, an MRI, or an MRA, sorry, or an angiogram? Would you guys tell me who will say yes, who will say no? Put in there A or B. So there's one say duplex ultrasound, Doppler ultrasound. Any other imaging study? Nobody wants to do a CTA or an angiogram? One person wants a CTA. Okay. So before we decide, if this person needs a CTA or not CTA, the question that we have to really ask ourselves is, does this person need some intervention? Is this intervention going to be medical? Is it going to be surgical? Is it going to be either, both of them? So we need to kind of have that decision made. And then the second thing is, really to make that decision, we have to know what the natural history of this patient is. If we have 100 patients with the scenario I just gave you, how many will end up with an amputation over 5 years? If we have 100 patients with claudication, have ABI with between 0.5 and 0.9, what do you think? So I want you to give me an answer, what is the right intervention, A, B, or C? And for the second one, you can say a number for the percentage of amputation over 5 years out of 100 patients with claudication. So let's see what you all say. So 3%, conservative management, okay. Multiple people are saying conservative management, which is more medical. Less than 5% amputation rate. Yeah, so this is really important because for any disease, before you think about the intervention you want to do, you have to think about or know what the natural history of the disease is. The natural history of the disease is meaning what will happen if I really don't do anything to these patients? These studies have been done almost for everything in the past when there was no therapy, right? Or sometimes a placebo gives you that kind of a study. So what I can tell you is for claudication patients, the natural history is that probably 1% per year amputation rate. So over 5 years, there is probably going to be 5% amputations, major amputations we're talking about. So whatever therapy you want to introduce has to have a better result than the 1% amputation rate per year, which is going to be very hard to do. And I can tell you in the 1990s, there was a study done where some enthusiastic interventionalists wanted to do angioplasties on claudicators because they wanted them to walk a little bit further and have a better quality of life. And what they ended up was, when they did that study, there was 6% amputation rate. So imagine when your therapy becomes worse than the natural history of the disease. So it is critical, therefore, in these patients to take that into account and not push the envelope trying to improve their ability to walk, because you may actually be the cause of their amputation. So in this group of patients, therefore, the right answer is A, you need to provide them medical therapy and maximize their medical therapy and risk factor modification. So I know we are probably past half the hour, and maybe I have a few more slides to cover this specific topic with few more slides. And you know, I have here this slide that really brings all those medical management algorithm, and you know where you start. You start with the patients that have limitation to walking. There are medications and exercise. The exercise part is really one of those critical elements that you need to keep in mind, because that is also the one piece that gives the most durable
would you please mute your mic?
Filmon, Michael, mute other go, please. Filmon, so mute your mic, please, or don't talk. So in this particular situation, therefore, we have medications that have been approved, at least in America, by the FDA, and there are also this proven exercise therapies that have been recommended by a lot of actually randomized clinical trials. So let's go over the two drugs that have been approved. So there is one that's pentoxifillin. You can see the dosage there. And this is a medication that has been used for many, many years. As the slide tells you, the overall benefit is really not clear. It is said that it allows the red blood cells to be more pliable, and move through the capillaries easily. And there is a lot of actually patients that swear by it. One known advantage actually of pentoxifillin, more than peripheral arterial disease, is actually for venous stasis ulcer. That's a drug that I prescribe very often for those kind of patients, even if they don't have any vascular disease or arterial occlusive disease, but venous disease. The second medication is cilostazol, and the commercial name is Platol. This is a phosphodiesterase inhibitor, and this is one of those drugs that has really been shown to improve treadmill walking performance. Actually, patients' quality of life improves, as evidenced by questionnaires that have been done compared to placebo. And what is really interesting about this drug is when the study was done, randomized, double-blind actually study was done. Cilostazol worked for those who took it, and then on the second part of the trial, when they took it away, they actually regressed. And so it has been proven twice, both in improvement and also when you take it away in causing, the symptoms to regress. This is a drug that has a black label box on contraindication-wise that you should not be giving it to patients with congestive heart failure. Other than that, it causes very often headaches, and so you need to strategize with your patient as to how to manage their headache. Sometimes you want to halve the drug dose. You want them to take it at night before they go to bed, and you can slowly increase or increment this over time. There are some other medications, including an ACE inhibitor that you see, Ramipro, and this is an ACE inhibitor that has also been proven to actually improve treadmill walking time in patients, and also over a long period of time, their perception of better quality of life and improved perception of walking performance. And so that's a drug that is used as well, not as much as the other two. And the other two drugs that you see below, particularly the cholesterol lowering simvastatin, is has not really been proven to impact directly. However, its benefits from the cardiovascular disease perspective is so clear that these patients need to be on some cholesterol-lowering drugs. And in fact, in our vascular surgery clinics, patients, if they are not on aspirin and cholesterol-lowering drugs, they are automatically put on that. There are some other, drugs that have been particularly, to stimulate angiogenesis. These drugs have been tried by intramuscular injections, intravenous injections, and intraarterial injections, and so on, and so subcutaneous injections. Although in the smaller studies, they showed some improvement in angiogenesis when muscle biopsies were taken, but at the end of the day, they really did not pan out to be useful to improve walking abilities and distances. What is really, really important and that you should keep in mind is there is nothing that is as critically important as walking exercise. And the exercise therapy part, be it supervised or home-based or resistance training or even upper extremity ergometry, meaning, these patients are working, the other muscles, if you will. They may be having arthritis, right? They might be having some other problems that might be limiting them as well from exercising. But what this is telling you is exercising in general has a major positive impact on or benefit on peripheral arterial disease, and particularly the supervised treadmill exercising is the one thing that has shown the most benefit. Partly you can imagine if you have someone coming to your clinic and is on a treadmill 3 times a week, walking through with a therapist and pushing the limits of the claudication pain that they have. Basically, those kind of patients over a short period of time, usually within 3 months, can even double the distance they can walk. And that might be all what they need to actually feel better and do their day-to-day activities and work that they want to accomplish. The home-based walking exercise works as well, but you can imagine how if patients are not supervised very closely, sometimes they may not be compliant. And so that is why the supervised treadmill exercises actually probably had the much better results. That said, at least here in America, the supervised treadmill exercise is usually not covered by insurance, and unless patients pay out of pocket, it is very hard to do. Although lately there are opportunities to kind of put it together with what we call a cardiac rehabilitation, and so through this cardiac rehabilitation exercising, we can include also supervised, be it treadmill or even a stationary bike exercising for these patients in the clinical setting. It is really, really important to stress about walking. And one thing I do, when I prescribe the walking exercise to my patients is I tell them that at least 3 or 5 times a week, they need to dedicate an hour a day. It can be at the beginning of the day, it can be at the end of the day, but that is the time, that hour, they are going to spend exercising for their legs. This is exercising against the claudication pain they have. So what I tell them is, just find your place. It might be in the backyard, it might be going out for a walk, but just make a routine effort to dedicate the hour. You walk until you get pain and you cannot walk. At some point when you cannot walk, of course, you have to stop. As soon as the pain goes away, you start walking again and push to walk through the pain. And literally what they say, no pain, no gain is true in these situations. And so I encourage them to do that on a regular basis, at least 3 to 5 times a week. And usually, if you couple this with what we call the Platol or the Salestazole medication that I mentioned earlier, actually those patients may get the best walking improvement, and they don't need any interventions. So when do we intervene? We intervene if there is no response despite the exercise therapy, despite the risk factor modifications. And some of these patients may be very young. And if these are young patients and are working, and this impairment is serious enough that's affecting their livelihood, meaning they cannot work and they cannot basically earn their livings. So those kind of patients, you need to think about taking care of them, although there is still risk of intervention, but you really don't have much choice. Imagine if this is a day laborer and has some claudication pain. If the day laborer is, say, carrying, heavy stuff, the distance that person can walk is even shorter because the workload is going to increase because this person is now carrying even more things on himself. And so there are situations where we would be eager to treat if their risk factor modification and if their exercise therapy you gave them for 12 weeks or whatnot do not work. The other area where we have been a little bit more aggressive lately is for inflow disease. We call inflow disease anything that is really above the inguinal ligament, anything in the iliacs and also in the infrarenal aorta. If these lesions are amenable to percutaneous therapy, it's usually a very durable treatment, and we have actually a good, relatively good outcomes. And in younger patients where we have no good response and their livelihood is compromised, and based on the morphology of the lesions, we may offer them an intervention. And so this is a time, therefore, when you will get an imaging study. An imaging study is really necessary if you decide to do an intervention. Otherwise, it's not worth it. So maybe next time we're going to go to the next level, which is going to be patients that presents with a more of limb-threatening situation. Remember, the individual we talked about up to now doesn't have limb-threatening issues. It is probably 1% a year risk of amputation. But a patient like this, which I have on the slide now, an 81-year-old with have a black claudication, which is no less than 50 meters, and has also an ulcer that is not healing. And on top of that, there is also pain that wakes this person at night. The risk of amputation of this person within the next 6 months to a year is more than 40%. And so this is a person or a patient where you will have to be more aggressive. And I think maybe I will reserve this for the next time. And I will pause here because we have about 15 minutes for additional questions or clarifications if you want. And maybe others who are on the call, I don't know if Malaku, if you see any of our cardiology colleagues, if they want to do some comments, or I can maybe go out of this share and see if there's anyone that wants to ask questions and also make any comments. So I'll stop here. Okay, Windows.
Yeah, it was a very nice lecture as usual. My question is, the capillary filling sign. We use a lot, capillary filling sign. How valuable that is as a physical exam?
Well, it is an important exam. It's an important exam, of course, if you are longitudinally clinically evaluating that person, right? So is this person, say, in a shock? You know, of course, the capillary sign, when it improves, you can see how the shock is also improving. I think for peripheral vascular disease, capillary filling usually is not something we rely on. It's usually not a test or not a physical exam that we would document, because we know there's some physical occlusive process on those patients, and sometimes capillary refill is also a function of how warm or cold the extremity is, and also, you know, a function of you know, a very subjective function, you know, of the person who is doing the test. And so for us, it's usually used if you have an initial assessment of someone who's seriously sick, but from vascular disease perspective, we usually don't document it that often. Any other questions?
You mentioned ramipril. What about other AC inhibitors?
Well, that is the only drug that has been actually tested, and you know, the problem, I think, from the FDA perspective is that the sample sizes in all the comparative studies were relatively small, and that is why. But I would just think that most of our patients are anyways on ACE inhibitors for so many other reasons. So be it, you know, hypertensive reasons or cardiac reasons. That said, you know, I think there is role for ACE inhibitors, and I mentioned that particular ACE inhibitor because that is the one that has been tested. Granted, it was, you know, relatively small sample sizes. So let me see on the question side here. What is the place for anticoagulation in PAD? You know, there is really no role of anticoagulation in PAD. We don't give any anticoagulants except for antiplatelet agent, particularly, you know, aspirin. And that is also given not so much for the peripheral arterial disease issue. It's really given more because of the association of coronary artery disease. Remember, by the time someone has a vascular disease that is manifesting, the likelihood that those patients have a coronary artery disease is extremely high. And in fact, if you look at, say, if you have 100 carotid stenosis patients, and statistics tells you that probably about 30% of them have diseases in the coronaries that might need revascularization. That's how bad it is. And therefore, if you talk about aspirin, it is usually not for the PAD. It's really more for the other issues. If you look at all the other benefits that may come with it, be it from mortality or whatnot perspective, it is usually more of the cardiovascular protective effect of all these drugs, particularly the statins and others. Remember, vascular disease patients, mortality at 5 years is 50%. And so whatever improvements you do because of these medications has also a direct impact in improving mortality because it improves the cardiovascular risks and improves the cardiovascular health. So this studies, you know, there's another question about, you know, aspirin versus clopidogrel, and you know, that is another, you know, antiplatelet agent. There has been a study actually in the past. There was a multinational study. It's called Charisma, and it has not shown to have any benefit to get asymptomatic vascular patients on Plavix. Plavix is clopidogrel. And actually, even in those who are symptomatic, the value is very questionable. So in our practice, in vascular surgery, we use Plavix only in the peri-procedure phase, particularly if we are thinking about a stent in the iliacs or in the SFA, and we would probably put them on Plavix for the first 6 to 12 weeks. Just taking the same analogy that cardiologists have shown in the cardiac space. And so otherwise, you know, really and truly, other than an increased risk of bleeding from the Plavix, there are no additional benefits that Plavix will bring. So, and it's costly, it's expensive unless people have insurance, and therefore we do not recommend Plavix for our peripheral vascular patients. Even aspirin is coming into question these days. I don't know if you guys have been reading about it, particularly the increased risk of bleeding from aspirin in the elderly is being questioned. But that risk is still being evaluated, and in the vascular surgery community, we are not shying away from ASA or from aspirin. So I think the question, what is the place of anticoagulation in PAD? Well, again, for atherosclerotic occlusive disease, we don't really use anticoagulation, but if we have embolic problems, that's when we put patients on a short-term anticoagulation. We may put them up to 6 months of anticoagulation, but it usually has to be thrombotic or embolic situation that may lead to failure of a revascularization. So the revascularization might have been with a bypass, or the revascularization might have been percutaneously. So in those kind of patients, we would usually put some anticoagulation recommendations for a limited period of time. Is Henok on the line, or Tesfaye, or Milkias from cardiology? No. So for most of you in Ethiopia, I think the area of vascular disease might be still not well defined, and I know at Tokor Ambessa we have our vascular surgeons who do vascular surgery and take care of vascular patients. In many parts of the world, this is a disease that is taken care of with, in a multidisciplinary manner. So it requires a little bit of a cardiologist, most importantly, preventive cardiology, because they really look into the risk factors and risk factor modification. It's also important to think the interventional radiologists to be also a partner in this, because they can revascularize and help you out. And the vascular surgery discipline, at least here in the US and in Europe, has transformed itself by taking care of the entire spectrum of vascular disease treatment. So we basically end up not only medically managing them, but we also manage them percutaneously, meaning we do our own angiograms, we do our own angioplasties and stents. We do also, of course, all the bypasses, which hopefully my part 2 is going to be more focused on the surgical part to treat that 81-year-old, which I showed you earlier. And so stay tuned to that. So there's one more question here. Which arterial disease are labeled as PAD, which are not? So in the classic screening definition that we have for peripheral arterial or atherosclerotic disease. If you use a definition of, say, defining that by ankle brachial index, anything that is less than 0.9, in the screening mode are considered to have, atherosclerotic disease, and those are considered as PAD patients. Anything that is, palpable and up between 0.9 and 1.4 is considered normal. And this is true, of course, for the lower extremities, but you can do also a wrist index to assess if you have also an upper extremity problem, right? Because sometimes the subclavian artery occlusion may arise, and you may have an equal blood pressures in both arms. And in fact, this is also why when we do the ankle brachial index, we measure both upper extremities. One might be more than the other. Remember, these are potentially peripheral vascular patients, so they can have subclavian artery stenosis, or they may have innominate artery stenosis. And therefore, it's always a good idea to get blood pressures measured on both arms routinely. So here's a question that says, if the ABI is greater than 1.4, what should be the next step to do the diagnosis? What is the role of treadmill exercise test in the diagnosis of PAD? What is your comment on BBS in patients with PAD? I don't know what BBS is, but in the meantime, you can just type in what BBS is. That's the beta blockers. Okay. So in answering the first question, if you have an abnormal treadmill exercise test, an abnormal ABI, meaning it's greater than 1.4, that is why you need to have the pulse volume recording study, which you remember I mentioned that assesses the blood flow by calculating the volume of the blood flow during systole and diastole. And so the pulse volume recording can tell you exactly what you need, because that really is, the increase in volume is an increase in blood flow. And so the non-invasive test still can give you some idea about the blood flow. You can also use the Doppler waveform that I showed you. You can use, the amplitude, you can use the characteristics, the three phases, and really have some basic understanding about how the blood flow is through that. The other point that you raise is really a very important question, because you may do an ankle brachial index and the ABI might be 0.95. Actually, you do a physical examination, and the physical examination may show you that the patient has a palpable pulse. Clearly, there is a problem here, right? So you will say, well, this person has a palpable pulse, so he should not be having claudication. No, actually they can. And the only way you can elicit that is by putting them on a treadmill. If you put them on a treadmill, usually you run the treadmill at 2 miles per hour, you put an incline of 11 degrees, and you have them walk on this. Usually you run this for about 5 minutes. Claudicators will have symptoms manifest relatively quickly, because the work of walking increases. Imagine now you are making them walk uphill and at 2 miles per hour, so they are going to feel this. And so when they have the symptoms appear, then you do again the ankle brachial index, and you'll see a precipitous drop. Why the drop? Because when these patients are exercising, imagine what happens in those muscle groups in the lower extremity. There is vasodilation that happens. And now the muscles are asking for more blood. The blood vessels are dilated. So when the blood vessels are dilated, automatically the blood pressure in those vessels drops. And usually the increment of blood flow that should compensate this vasodilation is not going to happen, because you have some stenosis, some blockage upstream, and therefore the vasodilation is not going to be matched with an equivalent amount of blood flow coming to that muscle group, and therefore the blood pressure will drop. So after exercise, therefore, you will have a precipitous drop in the ankle brachial index that will show you or confirm to you, yes, indeed, this patient has ankle brachial, this patient has intermittent claudication. And thank you for reminding me that I should have probably mentioned that when I showed you the pulse volume recording study. So the beta blocker piece, this has, no significant, vascular relevance other than the cardiovascular related issues that it brings with it in terms of, the cardiac patients needing beta blockades in many instances being, a good drug for hypertensive care and also cardiac performances. Other than that, it really, is not usually considered a positive or a negative for vascular issues. So I think for the sake of time, and I have also to run to the operating room, so I thank you for engaged discussion. I'm looking forward for the part 2 to be given to you guys at some point soon. We are looking forward on Friday actually to bring back our panelists, those who presented on all those cardiac issues, and I'll also be there. And so you guys are welcome to attend next Friday, and we can go over, review what has been covered so far. So with that, I'll say goodbye, and we'll see you on Friday. Thank you, everyone.